Here. All right, so now put you on here, and then up, press go down, and then down, you're good to go. Yeah. So, listen, guys, I know people are going to be trickling in. The only reason we're trying to hold time is because we are like broadcasting this thing, and then they just tell me what to do. We'll just stay on time. And so, listen, it gives me great pleasure. I'm not going to, y'all know the routine that we've done since we started this is we haven't bombarded everybody with lengthy introductions, and so I think that's helped and been good. But DeLon Canterbury, very happy to have him here and to introduce him. So I will let you take it away, man. Beautiful. Absolute pleasure. Thank you. Yeah, man. There. Hello, everyone. Hope you all are doing well. What? I'm Dr. DeLon Canterbury. I am a board certified geriatric pharmacist and founder of GeriatRx. And so today we'll be talking about the importance of deprescribing, how we all have an active role we can play to reduce harmful medication use, particularly in our seniors. But more importantly, I want to show you that there are avenues that this can be a new model going into the future of value based care. So this is, of course, meant strictly for wellness and educational purposes. So anything that's discussed regarding your care should be with your provider. So for those who may not know me, I started geriatrics in 2020. All right. I was a burned out, angry pharmacist working in retail and got tired of the way our patients stuck the cracks at my pharmacy counter. I decided to step down and do things differently and provide concierge pharmacist services for families directly, looking at ways to reduce harm with meds, but also looking for financial savings opportunities, looking for ways to navigate some of this without the headaches that they've been dealing with. And so our mission is to coach senior facing clinicians and practices on how to implement and monetize deep prescribing and putting it into their practice in Claire clinics using pharmacogenomics and deep prescribing. So, since y'all may not know me from North Carolina, I have been featured locally on a couple of news stations, all in the last year and a half, talking about, well, COVID at first, but now I'm talking about the growing issue I keep seeing with our vulnerable population of seniors. And so, in doing that, I've had the opportunity to talk about overprescribing in medical needs in the nursing homes, and was featured on PBS sharing insights on how we can combat this using a team interdisciplinary approach to care. Now, let's start from the beginning. I was a pretty shy kid, I can't lie. I was born in New York. My parents came from Guyana, South America. And really, I was the shy one. Of the others of three, with my brother DeLon and Dacia, and my mom, Sandra and Stanley. I got into medicine because they love using herbs. They love using natural supplements. I was like, okay, what's the science behind this? How can I advocate knowing this medical knowledge? And so, growing up in Atlanta, after we moved from New York, I tried to find my own way and navigate how I could be the person I want to be using this to love natural products. So, the truth is, working in retail, I was pretty bitter after a while. When you're a pharmacy manager, you see things fall through the cracks. You feel helpless. You're driving a team to say, hey, get your metrics up. Knowing in your heart it wasn't how you truly wanted to serve others. So, shortly after I graduated in 2015, got pretty depressed, got pretty hopeless, got diagnosed with anxiety and depression, and started seeing some therapy to get some help on how to unpackage that. But what I found was truthfully, I was just a passenger in my own life, in my own career. I mean, I put how much money into my degree, and I still hate my days. How many of y'all felt like that? Just waking up, you feel like you're a slog on a wheel, right? So I'm not the only one. But I learned about one, more about myself in this journey than others. And it was really seeing that I wasn't serving in alignment in my higher purpose. I wasn't serving in the capacity that I've always wanted to do as a pharmacist. And so I decided to start a company that's led on serving. And that's what geriatrics is about. We help families who are frustrated with an expensive healthcare system. We help manage some of those medications that might be confusing. We're trying to reduce pill burden for those and look for cost savings. And of course, we have the caregiver's back. Like the caregiver's secret is having a pharmacist at the helm to help navigate some of those meds that their loved ones are on. We can't lie. We can't help everybody. And so we cannot help people who do not want to help themselves. I mean, they gotta have a little accountability, right? We're not saviors. But we can't have people who just want an easy way out. There has to be a team based, energetic exchange to get people off of medicines using integrative approaches. So, what do? How does it all work? We require pharmacogenomics testing for all. And what does that mean? It means we test your body to see if there are any drug interactions with, well, you, without you taking a single pill. All it takes is a simple cheek swab. I get that kit delivered straight to your home in about 2 weeks, and I get a report that tells me, hey, based on your genes, you need double a dose of oxycodone. Or based on this, you should avoid opioids altogether, whatever the case may be. It's great for sight, it's great for cardiovascular disease, and it has tons of utility. But what I like most about it is that it's even telling me what hypersensitivities there maybe are, or what could have happened had we had genetic testing. So we also provide comprehensive medication reviews. We look for deprescribing opportunities. So we take a medication therapy management session and 10x it using the geriatric lens and then using assessments and tools to reduce harm. We work with the care providers and we look for ways to really minimize that back and forth and make things streamlined in care. But I can't lie. I think we all know deep down that our healthcare system is broken. Like it's not new. And that's why a lot of us are here today to combat this system. But we have 275,000 people that are hospitalized each year just for medications, which we intend to help patients. So that costs our system close to $600 trillion every year. How are we attacking that? Why aren't we addressing that? Isn't that what value-based care should look towards? If we can at least change what we're doing wrong and continuously improve. I'm tired of these stories when I go to nursing homes, when I go to caregiver events, when I speak and just keep seeing the same thing. Where were you 5 years ago? Where were you when my uncle was dealing with this and there were no pharmacists talking about these meds? Like, I'm moving on, but 750 seniors are hospitalized each day in our health system. You can't tell me it's working. And we got to do better. And the worst part is, my grandma, pictured here, Mildred, she was a statistic in that. She was in a nursing home in New York and had some non cognitive impairment. But instead of letting her ride, they decided to treat her with uh, classic drugs that I truly hate. Antipsychotics. Gave her Seroquel. Oh, no, it was a Prazodone, actually, in this nursing home. Really to chemically sedate her. And we found that it worsened all of her dementia symptoms. Go figure. So my parents are caregivers, also immigrants, don't really know the system, and they're trying to navigate how do you. Needless to say, the nursing home kicked my grandmother out because it could no longer manage her behavioral symptoms in New York. So now my parents, full time, 3 kids, had to move her from New York down to Atlanta and do it all over again. Figure out caregiver, figure out home health, all the jazz. All because of one medicine which we didn't know until 4 months later. So I'm thankful to this day that Rite Aid pharmacist who caught my grandma's med and advocated and had it stopped over 2 weeks, and then she got better. Her symptoms resolved back to her mild impairment self. So that was a pretty damn close call. Can I say that? So keeping that in the back of my mind as I got into pharmacy, as I got into retail, I kept seeing the same patient profile. Tons of meds, and me just saying click, 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 go away. I was burned out. And I started hating myself. I started hating my patients. I started hating my team. I knew I wasn't helping, right? So I had to ask myself, what can I do for the rest of my life? Because it's damn sure not going to be this. What can I do to be happy again? And I said, I'm just going to have to do my own thing. And that's where geriatrics comes in. We look to train passionate senior care facing providers on how to use deprescribing, whether it's pharmacogenomics, whether it's just using a simple Beers List assessment and saying, hey, based on your false risks, we should probably stop these opioids and benzos. I don't know. Or, well, additionally, we continue to empower and educate. I mean, that is the baseline of advocacy. That is the baseline of really driving about change, motivational interviewing, assessing if people are ready to adopt behavioral changes. That's what's going to help their family for generations, not just that one med review you did. And so, within those 3 months of me trying to figure out how am I going to get paid doing this, we had our very first patient. She was a 7-year-old woman, as pictured here, who was on 36 medications. Yeah, I didn't stutter. 30, 36, 36, 36 meds. This woman was barely 90 pounds. And she was in and out of nursing homes. And no one thought, I wonder if this might be an issue. We were able to intervene and advocate like that pharmacist did for my grandmother and got her down to 8 medications over the sum of a month. We were able to only not just do that, but we were able to serve as a medical expert in court because this woman was about to be involuntarily committed because her family wanted to seize her assets. There was a dark side to it. Half of her family wanted to throw her into her home so they can get her house and get her money. The only one who didn't was her caregiver, who's pictured there with me. And she was the one who hired me to say, I think it's the meds. So let's be real. The true advocate was the caregiver. I just helped her along the way. So deprescribing literally started with the caregiver. Let's be real. It started with her saying, I think there's a problem. Let's fix this. So let's not think deprescribing is just the doctor says we can stop it now. Great. Yeah, at the end of the day, you have to get that. Sure. But it's a multi layered process and it takes multiple steps to get to that point. So, some of y'all who know how much it costs to be in a memory care unit per month, like 8 to 15K, Cali is like double that. So just looking at that cost of witness alone, I'm an NF1. But this one patient has saved over $250,000 today. And this happened 2 years ago, just from one med review. So that's the power I feel we have. And I guarantee you it doesn't take a PharmD to make that happen. So what did I start to do? I started to volunteer. I started to get my hands into any geriatric facing community and just talk about the problem. I stepped down from Walgreens. I built this business. I served on a local African American Children's Task Force. I started just getting my hands in the streets to see what do people most need. And frankly, I wasn't really living for me before I started asking these questions. I was living for other people. I was living for other people's dreams or what I thought would be best for me, like my parents or social standards. We were not, we should do this. And I wasn't happy. I just had a bunch of titles mixed. Truthfully, I was an angry pharmacist. So he said till I died. I was really angry. I hated everything. Like I was just that guy. Um, but again, diagnosed with depression and anxiety, hated my life. But truthfully, I wasn't serving in the way I wanted. So in 2020, I stepped down. I started doing things randomly. I don't know how to build business. You think you do, but you don't freaking have a clue when you're just coming out of school. But I started serving, and that was my like I wake up every day moment. And that leveraged into me being a guest speaker, a publicly paid guest speaker, leading international conferences, talking about how we can change this role that people still think is a old guy behind a counter counting by fives for a pill. It's not like that anymore, guys. I started doing webinars in the community during COVID. At first, they're like, "Who are you?" Because they're close. But I started doing a series called Drugs Without Law, focusing on genetic testing, overprescribing, COVID updates, and more importantly, how to spot signs of DPLs or IAPLs. Please. which are the activities available for those who don't know. But the truth is, we have a huge issue. I mean, yes, the opioid pandemic is still here, not a heroin pandemic, but it's been going on for decades, guys. We've been over-treating everything, over-diagnosing everything, over scanning for something for everything to get those bills up. But with this fact alone, we got almost 5 million hospitalizations just from the mere habit of our Western habit to just prescribe, 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 prescribe. We can do better. And so it's even estimated that in the next 10 years, that there's 150,000 more deaths because we're not being on the overprescribing issue. There are barriers, I'm not going to lie. Deprescribing is a whole ton of fun to unpack like a Rubik's Cube. But there are barriers that are obvious. There's our perception of, you know what? Taking a pill, I feel like you're giving up on me as a patient. You really want me to stop. I'm losing trust in you as a patient provider. There's also clinical inertia. There's polypharmacy. There's prescribing cascades, right? There's just a simple mindset of, I don't have the time to talk about this. And that is the key we're going to try to target today. There's also, of course, our culture. There's professional etiquette. I cannot express how many times I hear neurologists or nephrologists say, oh, the cardiologist wrote this, but you know what? I'm not going to touch it. Walks away. I'm like, sir, there's an adverse event in front of your face. Do you want to advocate at least? No, I didn't touch it. It's fine. I'm not trying to blame prescribers, but there's a lot of ego in this. There's a lot of ego, and that's what's killing our patients. From just '08 to 2011 alone, 9 million patients were hospitalized because of adverse drug events. Older age and chronic morbidities, of course, have higher risks of having worse outcomes when that's included. And here's the kicker, guys. During COVID, this article actually came out September of 2021. The New York Times did an investigation across hundreds of nursing homes across the country, and they're finding a 21% increase of phony diagnosis codes for schizophrenia in nursing homes. Your clinicians in the room? Yeah, exactly. Her face is appropriate. Like, what the F? Yes. That is nonsense, guys. You don't get schizo unless you're like you're an adolescent age, right? We know that as clinicians. Yes. Prescribers know to work around to avoid that FDA ding for their facility. And so what they would use is this phony diagnosis code to then give said antipsychotics that put my grandma into the situation she was in that I discussed. So with that, yes, they don't get dinged for now using these antipsychotics because guess what? They're strapped. They're overworked. They don't even have a labor force. They just got to find ways to survive. So I understand it's a rock and a hard place, but ethically, this is not what we're supposed to do. And that's not why we got our degrees, to lie. But the worst part is, I mean, it's great. It's good on the science end, but we're only going to get older. We're only going to get older. We're doing better with medicine where people can live longer and healthier lives. But we don't have people to take care of them. We do not have senior care providers. We don't have enough. We barely have geriatricians, right? To have the mindset to think through these complex pathologies and learn how to deprescribe and advocate for deprescribing. So yeah, right now they're about 14% of the population, but in about 2050, they'll be about 33%. That's almost double. In fact, we're looking to see that they're going to probably be purchasing 50% of all drugs on the market by 2040. So we have a small population with less providers who are using the most drugs. I think y'all see the picture I'm trying to paint. Hospitals are losing jobs for nurses and other people in the healthcare sectors. Nursing homes are losing jobs as well. Assisted living homes, all negative, all in the red from COVID, and they're still trying to make those ends meet. We've seen more physician office jobs opportunities open up, sure. This is from the Bureau of Labor and Statistics, by the way, between 2019 and 2021. So Overall, 220,000 jobs lost in the nursing home sector just alone. Just alone. So, yeah, it is a rock and a hard place and a harder place for the caregiver. And the burnout we know is real. There's such unpaid demand on these families, on these homes. 43 million, 1 in 5 Americans serve as some type of unpaid caregiver. 17% of caregivers who describe their health for the caregiver alone as just being poor. And so we've had sessions today addressing how to combat that stress and burnout. And here's a piece that I want to introduce: personalized medicine, using genetic testing as a way to get better with our prescribing habits. See, the old model, we basically use a one treatment for everybody. If Susie, John, and whatever Candy all come in and sprain their knee, they all get the same medicine, right? That's the old way of doing business. We got technology and we have really accessible and covered costs for kits and services to get genetic testing done, where we can now personalize which medicine a person can take without, again, putting them in harm's way. And if you're working with seniors, you're not going to just throw on an SSRI, which is a selective serotonin inhibitor, and increase falls risk without knowing what their genes are doing, because you can significantly cause harm if you don't know their genes. So this is, again, meant to improve prescribing habits. It's to advocate for de-prescribing unnecessary or harmful meds and reduce the trial and error model that we've been using to date. So how can we advocate for de-prescribing? Some quick wins just so you can take away with. The Beers List is easy. This is such an accessible tool. If you're working with seniors, get comfortable with knowing what the Beers List is, download it, but it's basically a list of potentially inappropriate and harmful medications that are found in seniors. They do it by disease state, by how well your kidney works, how well your liver works, and they just list the drugs saying, hey, if you're this and you have dementia, you should avoid this because of X, Y, Z. This could be literally just a talk a week, which you're around or in service, and just say, hey, this class of drugs will cover this week. Be on the lookout for why UTIs may increase, whatever. But the Beers List has been my easiest tool to use to advocate for de-prescribing, particularly in over-medicated cases. And they update this list every year, so they're due for another one. And why this is relevant really is because 90% of people 65 and up are taking some type of prescription. Okay? This is another tool that we use for de-prescribing. This is the stop-start criteria developed by a working group in Ireland, a coalition of geriatricians and researchers and other patient advocates. But essentially, the screening tool of older persons' prescriptions is meant to look for ways to stop meds that are on a list, and start is a way to assess if there are any meds that actually might be omitted. So that's a way to look for anything that may have missed in our care. All right. Another great tool, actually funded by the CDC and has been shown to reduce falls risks in community pharmacy settings and in hospital settings, is the Steady Falls Risk Assessment. I really love this. Not to mention it's from UNC. My teacher made it up, so I'm proud of her. But yeah, at the same time, 74 older adults still die each day from falls. How many of y'all know how costly it is to fall and be over 60? Like one bad hit, 100K, like easy for the rest of your life. And then your morbidity is another cost that we not talked about yet, indirect costs. Getting help around the house now, you got to change the whole house to get the right things in place. That's a lot. So I'm looking at de-prescribing as the cost reduction tool that we have been sleeping on in our professions. And it's not just for pain or cancer, literally the efficacy rate of these different types of health conditions. We have cancer, 25% rate of efficacy, Alzheimer's, 3%, hepatitis C, 47%, incontinence, 40%. These are metrics, okay, that aren't the best, right? We're kind of just trying. You know, when they say we're practicing medicine, we're really practicing, guys. We're at the drawing board still. We do get some things right. But again, chronic pain patients cost our health system nearly $600 billion a year. So we have to look at opportunities to maximize one, our pharmacists, but two, we need to make this the mainstay of conversation, especially if it's preventable costs. We've wasted at just one hospital system in 2014. They found that there was about 900 million to about $2 billion that they had spent treating preventable side effects. And that's for all ages. More visits mean more costs, more morbidity, and worse outcomes for the patients. So, I give you the gloom and doom, but here's the key. There are tools available to really combat some of these issues. And the first one I want to discuss is the Viome trial. And this actually started in Arkansas in 2016 at a small tertiary hospital. The VA uses this model and it's now expanded to over 112 sites ongoing, and they have been successful to date. No sites have failed in using this, showing that they are saving money and deprescribing within our VA system. So, the Viome mnemonic is based on the methodology from high reliability organizations like the VA. And so, for those who may not know what HROs are, they essentially believe in a continuous improvement process to have zero harm across the board. They just want no harm as much as possible. And so, in that mindset, they decided to say, hey, let's use the pharmacist with the physician and the med rec team, or should be a tech or medical assistant, and let's literally dig in to some of these drugs before they're seen by the physician. And so they looked at people who were on 10 or more meds. It was retrospective. You know how it is, it's costly to do a prospective, but it's retrospective trial. 3 month period. And in that 3 month, they really deprescribed 1,060 meds, saving about 84K. Now, to date, there have been 128,000 meds deprescribed from this study. That has been close to 1 million in cost savings in just the last 6 years. And that's cost based on um, basically what the health system would pay to administer that medicine for the patient over a year's time. So Viome stands for what is vital. So as we're talking about Viome, you're going through a drug list and saying, all right, is this omeprazole vital? Is this omeprazole important? If it's vital or important for the patient to live, they're going to keep it on. If it's optional or not indicated or treatment no longer needed, or of course they're going to assess if every medication has an indication, then they'll consider stopping the medication or having the dose and tapering off slowly. So again, this has been done over 100 VA systems and it's growing to date. And all this was really using a clinical decision tool within their EHR system. So the most opportunities for deprescribing were vitamins, supplements, and some pain medicines that were kind of used scheduled. They also found that a lot of antimicrobiotics were being discontinued and high blood pressure meds, along with anti-diabetic meds. Really, one of the reasons what they found for deprescribing were some patients were just really not taking it anymore, or some patients just simply had treatment complete. So, if the VA is doing this, guys, I think we all can have a huge opportunity to do this. So, I got to go to the Deprescribe study, one of my favorites. This was based in Canada. They had a little bit of a different system, as you may know. And in this model, they actually incentivize pharmacists per conversation to reduce falls risk in patients who are taking benzodiazepines. So, Xanax, Klonopin, for those who may not know. Those meds are shown to increase falls and fractures in our elderly, and they have a whole different side effect profile when you're older. So, that being said, they were looking for meds that they can easily stop using a pharmacist at the helm, and then the pharmacist had a practice agreement with the provider to help work together to reduce harm. And they did. They managed to have a 43% reduction of sedatives in just 6 months. And all they did was reimburse the pharmacist maybe $25 per intervention in this model. This saved about $1,100 when compared to someone who didn't go through this intervention in a community model. And they also increase quality adjusted life years by zero point zero 0.08, very marginal, but hey, you can still say clinically that they lived longer because of that intervention. There was also a cost analysis further done to extrapolate upon this study, and they were able to see how much more money can they save with educating both the patient and the provider. And then this one or that one, they actually sent brochures to people's homes who were flagged for high risk meds. They had a pamphlet, they came in, the pharmacist talked to them as well, and then they kept the continuation going of that communication. Even looking at the American Geriatric Society, they're looking for ways to really intervene by having not just the doctor speak to the patient, but having a patient advocate, having the caregiver involved in the care team, empowering everyone with just little tools and hints and what to look out for if the patient's having worse outcomes. So we got to look at deprescribing as an interprofessional effort. All right. I have a PharmD. It does not matter. It literally needs to be a unified effort where we all need to see that there's harm in what we're putting into our bodies here. So let's look at some of the core tenets of value based care and see how easily deprescribing aligns with it. Truthfully, we're trying to lower costs. Deprescribing saves copay costs and could potentially reduce harm that that medication could have caused. We're going to have higher patient satisfaction. Why? They're on less meds and they have less side effects. Sure. Stronger cost controls would reduce risk if more of our patients are under medicated, as in not over medicated, not in a bad way. Uh, that's going to help. And then, of course, there needs to be more alignment of our prices with patient outcomes and showing that, hey, this can be done. We want to ease the burden on our healthcare system, which is bleeding money, and we want to ease the pockets for our patients dealing with these pills that may not even need anymore. So I see deprescribing as a way to create a new service for your business. I think this needs to be like a quality Betty Crocker seal of approval, whatever you want to use as a metaphor. But like, I want this to be like the stamp of DeLon says this is great deprescribing, where people are actively practicing these habits, so that now that value based is what's going to be bringing you revenue because of that. And we frankly have people funding this type of work. The NIA actually has a collaboratory focusing more on dementia and Alzheimer's related diseases, and they fund people who are facing patients just like this to test out the waters, give them an educational pamphlet for prescribing opportunities, and empower everyone within the process. And so, why I like these guys is they're not trying to go straight, here's a prospective trial. They're really trying to mix the translational with the community piece. They're trying to mix the two and just do it. And that's what this fund was developed for us to achieve. So I don't want anyone to fall victim to overprescribing. This is my grandma when she turned 90. This was the last time I saw her. It was a month before I finished up pharmacy school in 2014. And I have to tell you that she was happy as can be. Like she remembered everyone. She was making jokes. I mean, it was like she didn't have any type of cognitive impairment at all. But I felt in my spirit she lived just to make it to that day. She did die a month exactly from that day, but peacefully, not from some over medication, not from just alone. She was happy and died in her sleep. We don't need to be wasting money on meds, and there's a better way that we can approach care. So, more good news. There's more studies. Show that we do this. What I'm tired of is everyone doing amazing stuff in these small silos, and we're not highlighting it. Like, it's not all bad. Trust me. Kaiser's doing it. They got the optimized study. Whole point of this was to look for patient-centered interventions and educate around what can we do to de-prescribe in dementia. And for those that may not work in that space, easy ones tend to be drugs that worsen falls, drugs that worsen gait, drugs that cause sedation, or drugs that cause confusion. A big one is anticholinergic toxicity. And I can get into that. The whole point is it can cause harm. All right. But they're looking for people who are on 5 or more meds, looking for the benzos, the opioids, and the antipsychotics, the Seroquels that my grandma was on. Kentucky's doing it. There's an assessment of medication optimization. Again, this was more rural and they have different settings here. It was a smaller sample, But just in using this approach and looking at providers, patients, and caregivers that have to be included, they found that in just, 6 months of follow up, they're able to reduce harm and reduce some falls. There's another study looking at Latino and African American patients in Colorado, and this was more of an interdisciplinary approach as well. This actually was a unique, and they used culturally sensitive information. So they were akin to what they were speaking to. They needed a trusted messenger to look like them. But with this impact of value based care, they were able to build trust and found that using positive language around deprescribing led to substantial outcomes. So I got more, guys. Trust me. There's another one, Shepherd Pratt Health System in the Northeast. They use a safe mnemonic to, again, reduce prescribing of opioids. And this is the kicker. This is a Jerry Psych unit, and they dealt with patients with chronic osteoarthritis and chronic lower back pain for years, okay? For years. In 6 months, they decided, all right, we're not going to do this anymore. We're going to say no opioids. Here's what we're going to do. We're going to increase the use of non-opioid treatments to reduce pain and see what happens to our patients. They use a safe mnemonic where they look at what's safe, appropriate, fiscally neutral, as in cheap, and what's effective. And they also use the 2016 CDC guidelines that just came out about opioids as well. So in doing this, they found in just 6 months, no opioids were prescribed at all. And this is in comparison to the last, 5 years, where they were obviously using a lot of opioids. And this is a Jerry Psych unit. I mean, they're going to want some Oxycontin at some point. But you get my drift here. Another example, for those who may not know, quality improvement networks are basically hired by Medicare to kind of audit the services that they render. And so there was an effort, actually, I believe, from Indiana down to Kentucky, looking at nursing homes and looking at pharmacists, medical assistants, and technicians to, again, reduce opioid harm. And why this is important are these metrics right here. These are HEDIS measures. So they're looking to see how these opioids can reduce some of those measures and high risk medications with falls, with pressure ulcers, with physical restraints needed. Those can be used to date against your facility if they're being overused. And so they're finding in just using this methodology, there was a 7.5% reduction in overall opioid use altogether. There was a tripling of non opioid agents to manage pain. And there was also a significant reduction in the pain severity score. So the pain is even better controlled. So how much money do y'all think they made or saved just from these interventions? And a lot of it was educating. A lot of it was saying, all right, here's the whole team. Let's educate together and do it together. No egos. This is another effort for deprescribing, again, looking at Alzheimer's patients. And again, we mentioned that financial literacy is extremely low in this population. They know that. But they were able, and actually they're actively recruiting for this one. They're looking to get about 11,000 people to assess over 9 months if any high risk or harmful medications may be prescribed. Again, in patients with dementia. So we're talking about the benzos, the falls risk meds, antipsychotics, and opioids. So I encourage you all to, one, accept that we need an overall medication mindset shift in this country, period, across the world. Overprescribing is an issue everywhere. But we need to see this as an opportunity to literally start leveraging our skills as we already have, not reinvent the whole workflow process, but focus on what's a quick win we can do to just educate, empower, and mobilize. And that's why I've created the Deprescribing. And so I'm actually coaching pharmacists, nurses, as well as senior facing communities on how to put this into practice and how to sustainably do this within our coaching cohort. We really have about 5 to 7 people that take this per cohort, but this is meant for people who are really passionate about senior care. So we have coaching along with it, case presentations, we go through evidence-based models, and we look for ways to give you a deep prescribing toolkit so you can put this into practice as we speak. Our next cohort starts in about 2 weeks. We cover everything from geriatric side effects, genetic testing, opioid deprescribing for dementia, and managing herbals and OTCs, and how those can easily cause harm in our seniors, which consume the most OTCs and herbals out of anyone in the country. So, with that, I want to leave you with any questions or concerns or thoughts or comments. Please text me. That's my personal cell phone on the screen. If you're interested in applying or just want to talk, I'm here to be a support. Yes, sir. Question, as far as the genomics goes, I know that we've been at this personalized medicine for what, since 2012. Yeah. Insurance is not covering pharmacogenomics in most circumstances. What has been your experience in getting testing approved, covered, and opinion now that CMS has come out and said they're looking to stop unnecessary genetic testing? Yeah, no. So initially, when genetic testing came out, there was terrible abuse and fraud. There were people scamming our older patients and not even rendering the genetic test in the early 2000s. Um, the landscape has changed. The landscape has changed. I will say tests now out of pocket 300 to 500 bucks. Yeah. Before it was 5,000 in the early 2000s. The next kicker is Medicare pays for it now. Depending on your indication, depending on your health conditions, and of course the prescriber, Medicare will actually pay for the kit based on your health conditions. Medicaid pays for it in certain states as well. Also, some commercial insurers cover it. TRICARE does cover it, but you'll have to go to a VA for that. So it's becoming more covered, and as you know, CMS covers it. More people will follow. But I guess in terms of what I've had to deal with, I haven't had any issues. My model, I generally use a cash payer model for my business, but for the times I've had to use insurance, the only thing they want is a prescribing or an ordering provider to be on the chart. And Medicare will pay for that. If you have an ordering provider, so you can have the patient's provider do it, or you can use the medical labs provider, which can be a little sticky, but no issue in terms of doing that. Okay. But it is becoming more covered, and I've found Blue Cross Blue Shield, United Health can be a little more lenient and more progressive in accepting those claims. That's a great question. Yes, ma'am. Medicine umbrella, and then talking specifically about the genetic testing for the purpose of prescribing or deprescribing. Does that include somatic and germline, or just looking at the germlines with the kind of mutations? Yeah. And I'm really not that smart at all. I just happen to know this. I'm using whole, so we're using full panels first. Full panels, yeah. Okay. So what happens if, in theory, there's a senior that is diagnosed with cancer and has had tumor, profiling, which you then need, obviously that route, like put that into your, yeah. Absolutely. So, but sure, honestly, the advent of personalized medicine and precision medicine is for cancer patients. Right. All of our most of our cancer therapies are genetic based, so you know what we're targeting. But honestly, yeah, it's like should be done. Right. In fact, most medical institutes do it. The problem is communism. We're still kind of in the dark. So they do it now, they don't talk about it. And that's why I'm like, we have to educate and, advocate. Great. But yes, great question. Yes, ma'am. No, this has been really interesting for me. So I'm by no means clinical, not a PharmD. I'm on the access side for manufacturer reimbursement. Yeah. So helping patients with our biologics and respiratory and in technology space. We also have oncology. Mm-hmm. But it's so interesting because I've never ever thought about the aging population, geriatrics, with the concern of overprescribing. Mm-hmm. My biggest concern is cost, right? Mm-hmm. And D is in dog. Mm-hmm. But I love that you brought this into the value-based aspect care that you eventually, I think, truly want it to work. Right. Absolutely. But yeah, I just know where I'm going with this, but it's just interesting to see, yeah, maybe if we could stop the overprescribing and eventually maybe we can get these other drugs down and, costs, and again, especially for those costs. But yeah, I just appreciate this perspective that I never thought of. Yeah. I think in Medicare, I think in geriatric, and I immediately go to affordability. Right. Which is a huge issue too. Yeah. But let's get to the core of what can we reduce incomes. I think knowing the drugs is that's our go-to for treatment should be the first thing. So, one last thing. So, you seeing your customers, did you have a lot of Medicare elderly with more than okay. Yeah, majority are on that medications. And you were filling multiple scripts. The average age like had long-term care funds, and it was nothing for us. Listen, we slung scheduled drug like it was man. Every patient we averaged 9 to 11 prescriptions per 9 to 11 per patient. And on a new patient admin, we would start on 4 to 5, and by day 3, we had them on 9 to 11. And you can tell me drug interaction. Listen, if you didn't have a pharmacist, and we had 16 drivers we would send out every evening, and they would drive out all of them. Now, since then, that contract was absorbed by, I'm not going to poke fun at people, but Cardinal Health. And if you think Cardinal, you think Cardinal Health cares as much as an independent long-term care, let me assure you they don't. And so this becomes a bigger issue. Yeah. But yeah, 9 to 11 was normal. Yeah. It's ironic that it's worse if you're in a nursing home versus community senior. Yeah, otherwise it's polypharmacy. It's almost like it's oversight because somebody's getting the money. You hate to say this, but it's just the forgotten or forgotten about population that nobody really cares about. I also want to add this because some of they have long-term care funds and they want to do it. They can't. They can't do the stuff that they want to do. This is like, I got some 50 beds. I got a quick review. They can't freely give the independent concierge care to get that long. They're stuck. So they're literally stuck in a different pharmacy care. And if they don't, and to his point, there are few and far between independent long-term care pharmacies left because the big guys have swallowed them up. Right. We lost all 22 homes overnight. Excel spreadsheet because it looked good. And then, of course, the nursing homes call you because they don't know. And they're like, well, Miss Jones, the new patient admin at 3 in the morning. We can send drivers out at 3 in the morning, 2, 3 in the morning. Cardinal ain't sending anybody out at 2 or 3 in the morning. So it looked good on paper, but now they don't have that level of, so it gets further away from the point he was proven. So I think it'd be really interesting to flip this and look at it from Medicaid waivers, not your Medicaid patient, waiver in every state. And I bet you're not going to find the same with prescribing because that's been thinking about offering forever and ever and ever. And it's truly what you would call a whole person. And so if you look at cost control with the waiver, long-term waiver, and it would be really interesting to see how low of a prescriber. Yeah. Yeah. I like that perspective. Yeah. Now that would actually let me know. Also, what do you say, like, I mean, this is kind of rhetorical, but the areas where there's just more over, like Arizona, for instance, everybody and their mother goes to retire. I don't know why you live in 150 degrees. Just my opinion. It's a try. Okay. Here, my mother-in-law, who unfortunately now has dementia, she's living in North Carolina. I live in Raleigh, Michigan, and we're carrying. Yeah, research trying. It was just mind blowing to me when I would take her to appointments how it was just almost like they couldn't get her out fast enough. And it was just cattle call. Yeah. And the pharmacist there, my sister-in-law, her mother actually, or her daughter actually, she's a pharmacist at Walgreens for 25 years. So on the flip side of that, she's just waiting for the day to retire because they don't have enough staff, and she has no choice. Right. She has no techs. Yes. She's overworked. Yes. And Walgreens will obviously not give them pay raises. No. It's just unbelievable. I had to see both sides of that. I have to just have a personal story about both those situations. But it's terrible if you ever have a family member going through that to see how they're treated like true numbers. It's awful. There's a Thank you for sharing that. One, you gave me triggered, so like you got me back to my own days. But no, there's a really dark satire. I'm a dark person anyway, but it's called I Care a Lot on Netflix, and it's about the nursing home industry where they involuntarily commit people and then they would buy their person's house as they're being committed. But it's feeding to that very same narrative. It's great. Peter Dinklage and everyone. So it's just I think it's a sore but real point. It's like I hate to say this, but we pretend to care. We pretend to care about our vets. We pretend. But when you face it and you have stories like that, you see it's just another cattle truck. Yeah, it's true. So we just gotta do that. And you don't want to blame clinicians and providers. I blame the system. Right. And it's easy to blame the system, but what else can you do? It was the systemic part. Yeah, yeah. Yes, sir. You're talking about the respect level, let's say, between clinicians. One of the big things that we discuss patient advocacy is empowering the patient to challenge their own position, and how that, in most communities, especially our elderly population, is not something that they're used to doing, right? Because they don't know. So to re-empower them and allow them to have a solution like yours is awesome. Um, I come at it from the chronic pain side of things, trying to understand that study. Did they measure quality of life when they were able to get all patients off of pain medication? Hey, you're talking about the nursing home one where we're looking at the QIOs. They looked at how many meds were reduced for opioids. They looked at how many non-farm drugs were used. I don't think they assessed quality of life. The only quality was like pain assessment score, and that dropped by like 1.3. It was like 7.8 to 6.6 or something. So it was a small drop in the pain management score, but I don't think they dropped it extremely, extremely. Constipation could be a whole nother compounded factor of cost if you don't address it head on. So yeah, yeah. And imagine if they start using pharmacogenomics with that. Whew, better than quality care. Yeah, I'm having my fourth spinal fusion done in December. Um, you can imagine cocktails doctors have me on. Have you heard of VR therapy? So there's a FDA approved headset. I think it's called something RX, but basically this is meant for people with chronic low back pain, and it's an FDA approved cognitive behavioral mindfulness therapy. You can get it approved. The PA process isn't as bad as it sounds, but they ship a headset to your home over 8 weeks. They teach you mindfulness, stress reduction, all for patients who had chronic lower back pain, and they were having significant results, and in fact, decrease in opioid use as well. I forget the name of it, but it's a virtual reality headset company that I'm going to start recommending for patients who have chronic low back pain. So, just a thought. We're getting out of that epidemic and stuff. I mean, Eric was here before you, and Eric has a lot of the opioid cases, and we just got through doing the pain injection for a spine case out of Detroit, unsealed case, $465 million in fraud by four physicians, and they were doing the fast injections, getting them hooked on opioids, bringing them off, and then running them back through. It's a rough deal, and so this stuff is, like I said, he was talking about the data. Get the data out there. It's got to be transparent. It's going to hurt to swallow. But I mean, we got to address some of it. We got I got a doc who requires that I use their laboratory. Yeah. Be drug tested twice a month. Wow. Can't. We try to ask you to use an in-network lab and find another office. You have to do injections every 6 months, no matter if they work for you or not. Wow. And you're right. Opioids, and I took my kids with me one time, and their comment coming out of there was, "They didn't listen to you at all." Oh my gosh. Wow. But that's what we think.